Hi, here I am. As promised, I am going to go ahead and record Lecture 1 and Lecture 2 for you to view at your convenience. I'm going to post it to Canvas this evening, and hopefully it'll be available for you tomorrow. I apologize for there not being any PowerPoint. This is a new recording area in the library, and I'm just trying it out to see how it works. If it works and it works well, then we'll just keep going with this. You guys can watch your PowerPoint or look at your PowerPoint as I'm talking. Sometimes it's helpful, even if you just want to put me as white noise in the background while you're cooking supper. Then you don't have to stare at me. Not that I'm bothered by that, but at the same time, you don't have anything else to look at, so I apologize already. We're going to talk about the first class, and if you were in the first class, we went through the syllabus, which most of you seem to have an understanding of. If you weren't there, please read it. If you have any questions, let me know. I'm not going to review that. We're going to go ahead and start with the foundations again. We're talking about mental health and mental illness and exactly how they're defined. And there really isn't a true definition of mental health other than the ability to successfully cope. When you're talking about someone who is mentally ill, the difference between mental health and mental illness is that coping ability. That is paramount. Mental health has to do with a lot of things. Mental illness does too. It has to do with your family. It has to do with society at large, your environment, where you're from. So you have to think that some practices that can be considered unusual for the culture that you live in may not be so unusual for the cultures that your potential patient, comes from. We'll talk a little bit more about that later with some examples, hopefully. Mental illness, dealing with mood, behavior, and thinking. Some examples: mood would be bipolar disorder, definitely some changes in mood with depression and also with mania. Thinking and behavior, behavior kind of encompasses all of them. Thinking is directly schizophrenia because their alteration in perceptions, alterations in thoughts actually are what create their reality for them, which is not always the same reality that we live in. Just know that if they are mentally ill, there's a criteria. They're dissatisfied with themselves, their place in life, their place in society. They usually do not have very successful relationships, and they have trouble with personal growth. Now, this leads back to the whole idea of Erikson's developmental crises and what people are going through at the ages that they're supposedly going through them. If you have someone, I use this example in class, who is 70 and are out at the bar, are they finished with intimacy versus isolation? Or were they supposed to be with dignity and self-disgust? Are they there yet? Have they passed through? Not that you can't jump over crises, but you'll always return to the one that you never finished in an attempt to finish it and complete it for personhood. And most personality disorders overall come from or stem from unresolved developmental crisis. I think of the antisocial personality disorder, and I don't want to get too far ahead because this is really a cool personality disorder to study, not to live with. But that's your sociopath, and that stems from trust versus mistrust, which they never achieve in infancy, and that is almost impossible to regain. Moving on. The DSM. By now, most of you have seen the DSM. If you may have used it, it's exclusively used in the clinical site. It is the taxonomy put out by the APA. It gives us a standard language, characteristics of a symptom, and helps us identify underlying causes. Now, each disease process, and these are disease processes, these mental illnesses are disease processes, has multiple criteria for diagnosis. It may be this long in the book, 15 or 20 things, or it could be 3 pages long, as in schizophrenia. And it doesn't really matter how the person presents as long as they meet the defining characteristics. In other words, if the person is to be diagnosed with schizophrenia, they must have 6 of these characteristics that have been there for at least 6 months. Now, my 6 could be different than somebody else's 6 and somebody else's 6, but they're all defining schizophrenia. I hope that makes sense. There are 2 axles, or 2 systems for diagnosis of the DSM. The DSM-4-TR is going out of favor. Not many people are using that anymore. Because it's an axle system, it seems kind of cumbersome and labor intensive. I don't think it is, but some people do. It has axis 1 being your psychopathy, axis 2 your personality disorder or your developmental delay, axis 3 being your physical signs and symptoms, axis 4 your stressors. Doctors give that a mild, moderate, or severe. And axis 5 is your global assessment of functioning on a scale of 1 to 100, with the greater the number, the greater you are functioning in society. So someone with a GAF, global assessment of functioning, of 21 is not doing well, whereas somebody with a GAF of 80 is doing fabulous. So the DSM-5, it's a little different. It's non-axle. They've combined the first 3 axes into one, so you get a psychopathy and a little flavor of their physical elements. I wouldn't say that's complete or all-inclusive, but you get a little bit of flavor with that. Then you also get a little bit about their disability, how well they function in society, their stress, and it's not given a number. Again, it's a mild, moderate, or severe, which I struggle with accepting, but it is what we are to be using now as professionals in the psychiatric world, and so we do. If you are at St. Rita's, you'll find this under the notes section in the doctor's notes. If you're at Coleman with me, I can direct you. Their charting system is a little bit different. Historically, mental illness has always been blamed on the gods or some external force in ancient times. Coming down, Aristotle, Plato, those guys, they believed in those 4 humors, and if we bleed people or we purge them, then we're going to, and not purge like the movie, but purge as making them vomit and things like that. But if we purge them, that they're going to get straight in their head, and that's not always the case. In fact, it wasn't the case at all with Aristotle, but anyway, I'm talking about opiate dependence and things like that. That's another topic altogether. Hang in there with me. Anyway, Aristotle. Then the Christians thought they were demons. They flogged them, they beat them, they tied them to the floor, if they even let them into a building. Dorothea Dix came around, and she helped with the moral treatment and the establishment of asylums in England and the United States, and that gave them a place to be. They still were not treated the best, but they were treated more humanely. Pharmacologically, it came about drugs in the 1950s. Thank God for Thorazine. Thorazine is an animal tranquilizer, and they use it in the mentally ill. We have also lithium. Lithium's a pretty cool drug. It's used for bipolar. We still use both of these medications. They are very old granddaddy drugs. There is monitoring with them, which I'll talk about when we get to medications. Just know that they used those, and it was kind of nice because it was the first time we actually had some sort of control over the mentally ill, some sort of assistance for them. Community in 1963, they started this deinstitutionalization. It was an idea of the federal government not to pay for asylums anymore. We were going to go ahead and we're going to take this money that we were putting into asylums, and they were going to give them to the communities to establish community health centers. And that didn't work very well. The money's still not here, and this was in the 60s. So we have a few, not as many as we need, because they really underestimated the need of the community, especially homeless populations who have mental illness. The deinstitutionalization was not really cool because, families did not want their mentally ill back home. They would let them be homeless. They would allow that. Or they, despite the fact the person was able to get a check now for his disability, they would not assist with helping them get their meds, helping them go to therapies, anything like that. So we had something that was called the revolving door effect, where people would be out, they decompensate, have a crisis, be back into the hospital. Economic burden for mental illness exceeds all types of cancer that's out there. It's really, really a huge problem, with a fourth of our population experiencing some sort of mental illness and being compensated for disability with it. It is a leading cause of disability in 15 to 44, and it's going up. Treatment is still lagging in the homeless. I will say it's still lagging in the prison populations also, and those with substance abuse problems, mainly because the insurance parity that goes with that. Physical ailments you can test for, you can do treatments for, but suicidal ideation, mental health conditions really don't have any kind of testing that you can do for them. The treatments by default would not be covered either. Unfortunately, this is really truthful, since we don't have a lot of community health centers, that we are going to be running into a lot of problems in the future. Homeless, a third of them have mental illness, half also have substance abuse problems, which, of course, if you're homeless and you have a nicotine addiction, possibly you're living under a bridge and you have COPD, and then you're not breathing and you're not getting any kind of albuterol or puffer therapy. Oxygen is going to be a big not having process. And then we're going to run into possibly patients who have diabetes because they are eating whatever's given to them, and they have ulcerations and amputations, and they are also mentally ill. And now you have someone who's completely out of control in a situation where they don't know who they are, let alone what's going on with them, and we want to take off a foot, or we want to check their blood sugar. That's going to be scary enough. Healthy People 2000 set us some goal for some physical ailments. Healthy People 2020 came along, and this is where you guys come in. Healthy People 2020. I'm hoping you'll help me achieve some of these mental health goals, and you can read them. It's reducing suicide risks, attempts by adolescents, proportion of adolescents who engage in eating disorder patterns, proportion of people who experience major depression, increase the proportion of primary care facilities that provide mental health care on site. St. Rita's has this idea, it's called the medical home. And there are community centers that are around the Lima, Kenton, Bellefontaine area that are considered medical homes. And in those places, they have dental, and they have psych, and they have specialty care, and they have pharmacies and things like that. Some of the things for depression that they can do, and for addictions, they have something called CAGE scan or survey. It's CAGE. It's for addictions, especially alcoholism. And then they have the Beck Depression Inventory. And we'll talk about Beck later. He's one of my favorites, so you'll definitely hear that name again. We want to, in Healthy People 2020, increase the number of juvenile residential facilities that screen for mental health issues. I don't believe they do at JDC or any kind of detention centers. That really needs to be, somebody needs to take that challenge on and see what we can do to help there. We need to increase the proportion of people who have serious mental illness who are employed. If they're medicated, people can work, okay? Increase the proportion of adults with mental illness who receive treatment, including dual diagnosis. That's really tied into the insurance. If we can get legislation to allow payment for not only mental illness but also for their dual diagnosis, we would solve a lot of problems. The unfortunate thing is that dual diagnosis or addictions is considered a personal choice by insurance agencies, and they'd rather treat retroactively rather than proactively. So until they come around, I think we're going to be dealing with this problem altogether. Let's see. Increase in service to the mentally ill in homeless populations. So we'd love to see that. Most of my population is homeless in Dayton. I'd say the bulk of them are homeless. And they do come to see me, which is kind of nice. I get more visits in the winter because it's warm inside and I have coffee and donuts. But it's good when they remember and they're taking care of themselves. Even if they don't have a home, they know that self-care is very important for longevity. Community-based cares, like I said, we didn't have a lot of money back from the government. So building these little pop-up stations everywhere where people can stop in or visit these community centers, like mine's a 28-day program. Few and far between. People prefer them to a doctor's office or direct, parts of group therapy. It's better to be individualized. They like that, but unfortunately we're not getting any money for that right now, so we're kind of stuck. There's the Health Parity Act. It was in '96. It said that we'll pay for mental health conditions if you have a business that's over than 50 people, but we won't cover substance abuse problems. So we're back to the square one, really, and it's state regulated. You have to consider the changes in family and what people consider family these days. You may have same-sex marriages, you may have blended families, you may have multiple generation families all in one household. And for the mentally ill, the stigma associated with the different cultures can be interesting, to say the least, in the dynamic as you're taking care of the mentally ill person. We had a patient not long ago that actually his mother refused to be his guardian because it was just too much pressure and too much work for her to do. Fortunately for us, a lot of lawyers here in town, doctors actually, will go ahead and agree to guardianship, not for money, but for health care reasons. And they usually are the ones that sign power of attorneys and things like that. So we are very lucky that we have lawyers that will do that. I don't believe in alignment. We have one doctor that does it, but I know in some of the bigger cities they do have that, as long as it's kept as a separate business and they're not their patient, I guess I want to say. So moving on. Linda Richards, our first psychiatric nurse. Belmont is where they did a lot of shock therapy, insulin shock therapy. They would take somebody who was not diabetic and shoot them up with some regular insulin until they seized, thinking that the seizure would actually reboot the brain. And it's a similar principle with electroconvulsant therapy, or ECT, is that the shock is going to reboot the brain. It has a lot to do, though, not so much with rebooting as it does with secretion of neurotransmitters. So that's how they worked. And of course, psychosurgery, where they would go in through the lacrimal duct into the frontal part of the brain and just kind of tease out a few fibers and increases docility and increased compliance. It wasn't very good for the patient at all. It's not something that needs to be revisited, I'm sure. The first textbook, The Nursing Mental Disease. It's kind of a funny title for the textbook, but it was out in 1920. Johns Hopkins was the first school in nursing to include psychiatric nursing, and of course, the NLN in the 1950s are why you're here in class with me. They said that if anybody wants to be accredited and approved, you must have a psychiatric course in your nursing curricula. So, welcome. All right. Hildegard Peplau, she's the one who came up with this whole principle of therapeutic use of self, using your verbals and your non-verbals as if you were using a stethoscope. It's a very interesting principle. This whole therapeutic talking techniques, they were all developed by her and by Jane Mallow. Mallow, she kind of just wrote in on Hildegard's, shirt sleeves or shirt tails or whatever, so I don't speak a whole lot about her. Hildegard is the one who primarily came through it. So the reason that we studied that is that it's very effective according to evidence-based practice, And the reason you need to learn it is because it is what we currently do in therapy, what nurses do on the floors, and how it assists in the care of individuals with mental health issues. I'm talking too fast and I'm starting to stutter over my words. I'm sorry. Okay, so let us talk about relationships. Relationships are interactions you have with other beings. People can have relationships with their cat and their dog. So the only ones that you can have a true therapeutic relationship is with another human, okay? I can have a social relationship with my pets. I'm not going to have a social relationship with a mentally ill patient, hopefully with no patient that I have that's mine. I want it all to be therapeutic in one way or another. But the therapeutic relationship is very different than the social relationship. It has a goal, and you definitely have to have a goal when you go in to talk to a patient. If your primary purpose is to talk with them, which nobody can not communicate. So anything you say to them non-verbally is still talking to them, which makes you have to be very aware. But anyway, you need to have a goal, focusing on the patient and helping them to achieve the goals that they have set for themselves by themselves. You lead them down the path. You don't advise, you don't suggest, you don't do any of that. You just guide them. It's hard. It will be hard for you. There are phases to the therapeutic communication. There is the orientation phase, where is the establishment of trust, and a lot of you are mentally ill don't trust anybody. So you have to be interested, empathetic, unconditional positive regard. Doesn't matter to me if my homeless people come in and you can see the lights jumping right off of them. I'm going to shake their hand and I'm going to welcome them with open arms. And you need to learn to kind of be the same way, regardless of what they look like, where they've come from, and who they are. You accept them for their humanness. So the working phase, that's where you actually get to sit down with someone and have a discussion over what they need. They will tell you, usually within, I'd say the first 5 seconds, what they want, what they want to talk about. They'll tell you. And you can pick it up and then go from there. But remember, you have to use therapeutic technique, general leads, exploring. If you haven't printed off that handout, print it off. All of those things will help you in establishment of a goal for them to work on, okay? You may have your goal, but it may change also. I tell people, when you're in a therapeutic communication, whatever your goal is when you're going in, that's fine. If there's real work to be done, and they bring it up and they want to talk about that, forsake the goal you have. Help them achieve their goal. But keep in mind, I want you to have your goal when you go in. Termination phase, you have to be really careful with termination phase. It's established during orientation. But the bad thing is if you've established a good trust relationship with this person and you've done some good work, they won't want you to leave. And then they're going to try a whole lot of different methods to get you to stay and talk with them. I had a student, probably been about 4 or 5 years ago, maybe longer, who the patient told her, if you leave, I'm going to take my sheet, I'm going to hang myself. Well, student had to leave. That was her responsibility to make it to post-conference. So she took the sheet, and she came and saw me. And we together went and saw the nurse and went back and saw the patient. That patient ended up having a secluded event where she was able to think about things, express herself, because during the secluded events, oftentimes you'll have another nurse back there talking with them therapeutically to help them establish the whys of what they were thinking. And some people just do things without knowing why they've done them, and helping them figure that out is very important too. Let's see. Therapeutic use of self, I think I've belabored that enough. There are a whole lot of different communication techniques. Take a look at all of them, and it helps us work our way up the pyramid of needs. The communication actually has a purpose. It has verbal and nonverbal components, and it works for the patient. If you use sentences like, well, my daughter or my family or I did it this way, that's not therapeutic. Okay, that's social. So you need to back it up a little bit. I stuck on there pictures of faces because I wanted you to be aware of what your face looked like or looks like when you're talking to a patient. You need to be very deliberate in the way you present yourself with an open posture, with a not staring, but a good direct eye contact, nodding, listening, leaning in. They're all very important. And if you don't know what your face is saying, I can guarantee you they know what your face is saying. And even without you saying, hi, how are you? I like you. You're a nice person. They're going to tell you they don't believe that at all. And then your trust relationship is gone. So you have to be really, really aware of what your body is doing, what your face is doing, in addition to what you are actually verbalizing. So the process recordings you do in clinical or an exercise in that, and hopefully it will be at the point where you can do it automatically, not have to think about it and be nervous about it by the time you finish. But we'll see. I'll help you as much as I can. Common techniques of therapeutic discussions. Silence is therapeutic. If they need to talk about something, you just be quiet and you let them talk. Exploring always starts with an implied or a present tell me. So the words tell me or say that again. Explain that. Things like that are they are considered exploring, and you'll want to say, can you tell me that? And don't say can you, because the minute you use can you is the minute that you've given them an option to say yes or no, and that's a closed question, and they'll say yes or no and then you're done. So if you just say tell me, then they have to explain themselves. Reflection is where you put up a mirror to them and show them what they're really saying. If someone is saying, I'm really angry, I don't know what's going on, you can say something along the lines of, you say that you're angry, you might be, no, I won't say that. What would I say? See, I even screwed up. You say that you're angry, but your face says that you're sad. Something like that. You reflect back and then let them determine if what they really feel is what they're really feeling. Let them put a name to it. Making observations is always, I see that you are sitting there with your eyes closed. I see that you are not understanding what I'm saying, that kind of thing. Active listening is just active listening, where you're actually leaning in and listening. Summarizing is, so today we talked about, and you summarize it. Restating or paraphrasing is taking what they've said and using your own words and putting it into the same type of verbiage. Somebody says to you, I don't know what I feel. And you would say back to them, you're unsure of how you feel? So that would be restating. And then asking relevant questions, asking questions that matter. Don't ask questions like, if a patient says to you, oh, I really feel like I'm going to kill myself today, and you say, it's a pretty day outside, isn't it? It's not a relevant question. Don't go there. And then encouraging evaluation. This is where you want them to tell you about a situation. If somebody says, I'm bad, you want to know what they mean by that. So you could repeat the word bad, or you could say, tell me more about that. You'll use different techniques to get them to evaluate themselves. Now there's a Kahoot. I will be doing it in class. I'm not going to do it here because, like I said, this situation is not interactive enough for me. And I'm just kind of sitting here and staring at you, and it's making me all weirded out. But anyway, non-therapeutic techniques, to skip ahead a little bit, closed questions. Overloading with questions is where you ask like 15 questions at one time. Don't do that. Giving advice and asking why. Oh, don't ever ask why, please. It's accusatory, it's hostile. Your patient will respond in kind. So don't say why. If you say why and you wish you could just suck it back in through your teeth, deal with it, suck it up, realize you said it, move on. Okay? And don't do it again. Lots of manipulative behavior by the mentally ill. You have to consider that they are going to try to not talk about themselves as much as possible. They're going to try to get you to talk about yourself. And being social creatures, we all love to talk about ourselves, me included. Okay? You just have to be aware that we're not there for us, we're there for them. Let's see. Another technique they may use is they try to be completely dependent. Oh, you need to get me some ice water and then help me walk to the chair. That doesn't always work. Not if they are fully capable of doing those things for themselves. Don't allow this dependent nature to take over. It's not appropriate. Sometimes you will have mental ill make sexual advances towards you. They'll try to hold your hand, rub your back, make a comment. I try to supersede that by saying don't dress showing inappropriate parts of your body. Don't wear leggings. Don't go without an undershirt. Still, you're going to have some patients that will be very inappropriate, and you can tell them when they're saying that, I'm sorry, that's very inappropriate, and then walk away. Okay? So they know their boundaries. You have to be a mother type to them, some of them. If you try that with a manic, they're going to completely go off the handle. So remember, when we're talking about all this today, we're talking about generalities. It doesn't work for everything. When we talk about specifics, I'll tell you exactly what works where. Okay? Okay.